Hello and welcome to New Drugs and Biologics. This will be presented by our industry residents, and my name is Ryan Garst. I'm the Senior Director of Clinical Services. None of our residents in this presentation have any financial relationships to disclose, and none of the residents in this presentation will discuss off-label and/or investigational use in their presentations.
Hello, my name is Charlie Nguyen. I'm one of the residents here at Optum Care Health. And today I'll be talking about Cusatir, which is the new IV formulation for cetirizine. So it's classified as a histamine 1 receptor antagonist, which was approved on October 4 of 2019. It's indicated in the treatment of acute urticaria in adults and children 6 months of age and older. And it works by selectively inhibiting peripheral histamine 1 receptors. And for dosing, it's a IV administration only. So for adults and adolescents greater or equal to 12 years of age and older, it's 10 milligrams. And children 6 to 11 years is 5 milligrams or 10 milligrams. For children 6 months to 5 years is 2.5 milligrams. And for adverse reactions, you may see some dysgeusia, headaches, paresthesia, presyncope, dyspepsia, feeling hot, and hyperhidrosis, though this is pretty rare. Next slide. It's applied as a 2 milliliter size amber glass vial for single use. Its average wholesale price is $360. And for storage, we want to store these vials in 20 to 25 degrees Celsius. However, excursion data does permit to 15 to 30 degrees Celsius. And we want to administer Cusatir as an IV push over 1 to 2 minutes, once every 24 hours as needed for acute urticaria. And some education and nursing consideration is not recommended in pediatric patients less than 6 years of age with impaired renal or hepatic function, just due to lack of data. And there has been some somnolence reported, so we want to instruct patients to exercise caution when operating a car or potentially dangerous machinery, and also to avoid use of alcohol or other CNS depressants. Next slide. In the study that they used for FDA approval, 262 patients were randomly assigned Cusatir 10 milligrams or diphenhydramine 50 milligram injection for the treatment of acute urticaria. The primary endpoint was the change from baseline in a patient-rated pruritus score, which is a score between 0 to 3, 0 being no pruritus and 3 being the most severe. And they assessed this 2 hours post-treatment for the intent to treat population. The pre-specified non-inferiority margin was 0.50 for the difference between the treatment group. And the table below here, you see the baseline mean for each of the group, and also the change from baseline mean. And the adjusted difference between the treatment groups, it was 0.06, which was well below the non-inferiority margin of 0.50, which showed that the effectiveness of Cusatir was found to be non-inferior to diphenhydramine. Next slide. They also looked at time spent at the treatment center. So it was 2.07 hours for diphenhydramine versus 1.71 hours for Cusatir. And for ED or clinic return after patient discharge, it was 14% for diphenhydramine versus 5.5% for Cusatir. Next slide.
Hi, thank you. My name is Ashley McCracken. I am a second-year pharmacy administration and leadership resident at Johns Hopkins Home Care Group. And today I'm going to talk about 2 different medications, the first being Givlaari. Givlaari is a small interfacing RNA that is directed toward the ALICE1 gene. And this is used for the treatment of adults with acute hepatic porphyria or AHP. The way this medication works is the small interfacing RNA causes the degradation of the ALICE1 mRNA on the hepatocytes. The lower ALICE1 leads to reduced neurotoxicity intermediates, and these are usually associated with the attacks of the disease manifestations of AHP. This is a specialty injectable at 2.5 milligrams per kilogram subcutaneous once monthly. Looking at the Envision trial, this was a 6-month randomized double-blind placebo-controlled multi-national study. This was 94 patients with AHP, average age around 40, primarily female and Caucasian. When looking at the trial endpoints, looking at Givleri compared to placebo, the mean rate of porphyria attacks was significantly lower in patients receiving treatment, and then mean days of use of Hemin, which is something to help with porphyria attacks, was lower when using Givleri compared to placebo. Thinking about contraindications, it's primarily just severe hypersensitivity, but there is common ADRs with nausea and injection site reactions. Thinking about monitoring precautions and warnings, anaphylaxis, hepatotoxicity, renal toxicity in injection sites, making sure that you are taking liver function and renal function tests regularly while undergoing treatment. This is a clear, colorless to yellow, ready-to-use solution in a single dose vial, and it has to be stored in refrigerated temperatures, and the cost is about $47,000 per single-use vial. In regard to patient counseling, the primary thing to discuss with patients is the risk of injection site reactions and nausea. Moving on to my second medication, Zolgensma. Next slide. Zolgensma is an adeno-associated virus vector-based gene therapy, or AAV9. This medication is indicated for the treatment of patients less than 2 years of age with spinal muscular atrophy with biallelic mutations of survivor motor neuron 1, or SMN1. SMA, or the spinal muscular atrophy, is caused by the biallelic mutation in this gene, and it results in insufficient protein expression. The way Zolgensma works is at the AAV9-based gene therapy, it delivers a functioning copy of that gene that encodes the SMN1 protein to allow expression. In order to undergo treatment, patients must test for anti-AAV9 antibodies, as if these are present, the therapy will not work. Looking at dosing, this is a unique dosing thing for this medication. It is dosed by vector genomes per kilogram of body weight, and it is administered IV over 60 minutes. You can see here a brief list of patient weight ranges and volumes associated with the dose. This can be found in the package insert of the medication. So the way it works is you must take a patient weight as close to the time of administration as possible and order a specific dose vial or volume for these patients. Additionally, these patients must be treated pre and post with oral systemic corticosteroid to allow better efficacy. Looking at the trials, there are 3 main trials for Zolgensma. One is completed, which is the first phase of the START trial, and then 3 are ongoing, the START long-term follow-up, STRIVE, and SPRINT. So the START trial was the phase 1 trial that was 24 months and then is going into a 15-year voluntary long-term follow-up. And then looking at the 2 phase 3 trials that are underway, the STRIVE and SPRINT, the only difference between those 2, STRIVE is symptomatic patients, while SPRINT is pre-symptomatic patients. You can see all here very small sample sizes, as this is a rare disease state, and the length of time for each trial. Moving into the next slide, I want to focus just on the START and the STRIVE trial, so our symptomatic trials. The START trial had a mean age of 6.3 months, with the primary endpoints looking at survival, sitting without support for greater than or equal to 30 seconds, standing and walking. Being a phase 1 trial, they really looked at the specific dose that would be efficacious for this medication, low dose versus high dose. And you can see here, out of patients receiving low dose versus high dose, there was more efficacy in the high dose, which is the recommended dosing that is on the market now. In the STRIVE trial, this ongoing trial had a lower mean age of patients, looking primarily at survival and sitting without support for greater than or equal to 30 seconds. They looked at this and compared to a natural control for patients that didn't undergo gene therapy, and you can see there is improved endpoints here, but the trial is still ongoing, so no statistical analysis has been published. Thinking about boxed warning for this medication, acute serious liver injury is common, so making sure we monitor the liver function tests before and 3 months post. Additionally, needing to be on the oral prednisolone for that therapy. Common ADRs are the elevated aminotransferases and vomiting. And then warning and precautions for the drug, according to the package insert, are the thrombocytopenia and elevated troponin, which also need to be monitored regularly. This medication is supplied in weight-based standard dosing kits. So the kit varies depending on the NDC that's ordered. It can be anywhere from 2 to 9 vials, and it also has an alcohol wipe per vial size. So like I said before, with the dosing of the weights, each dose range is associated with a different NDC kit. And so it's very, very dose or patient weight specific for the dosing. So just wanted to provide an example of this. At Johns Hopkins, our most recent Zolgensma patient was a 1-month-old infant who had the following dose overview. The patient was 3.8 kilograms about 3 days prior to the infusion. The Zolgensma kit we ordered is right here. You can see the specific NDC. The dose volume for this specific patient was 22 milliliters, which translated to 4.4 times 10 to the 14th vector genomes. Storage of this medication is very specific. According to the package insert, it must be frozen in the clear vial and upon receipt of the drug, immediately placed in the refrigerator and is stable for up to 14 days. The cost or average acquisition cost for this is $2.125 million, since it is a single dose and a potentially curative for this disease state. Patient counseling specifically for this drug, there is vector shedding in the feces, making sure you counsel patients, parents of how to appropriately handle feces after this for the next few weeks, and then the vaccine adjustment due to corticosteroid use. Thank you.
Hi, I'm Neil Patel. I'm a resident at Quorum CVS Specialty Infusion Services at the Houston branch. I'll be talking about mixed-redolent, or insulin human and normal saline. Mixed-redolent was approved July 22nd of 2019 for glycemic control in patients with diabetes mellitus. Symptoms of hyperglycemia include blurred vision, fatigue, confusion, fruity smelling breath, and as well as excessive thirst. Typical initial IV dosing is 0.1 units per kilogram per hour, which will vary based on the patient's response. Common adverse reactions include hypoglycemia, weight gain, and the long-term use. Serious adverse reactions include heart failure, arrhythmias, hypoglycemia, hypokalemia, as well as hypersensitivity reactions. Next. Mixed-redolent comes in 100 units per 100 ml single-dose plastic containers. Each container is $42 at AWP. It's a clear and colorless solution, and when storing it, it should be refrigerated and protected from light. One of the benefits of this product is that there is no preparation needed, which is really important since there are lots of compounding errors involving insulin. As for storage, the ready-to-use bag, when it's stored in the refrigerator, is good for 2 years, but it can also be stored at room temperature for up to 30 days. Once stored at room temperature, it should not be refrigerated again. For the nursing considerations, this is more for inpatient use than home infusion settings. So this is more seen in emergency departments as well as ICUs. And infusion time will vary based on the patient's response. And monitoring the patient frequently is required during the infusion for hypoglycemia and Mixrelin submitted as a type 5 NDA, which is for new formulations. To get approval from the FDA, bioequivalent studies were needed, which included pharmacokinetics and pharmacodynamics data. These were conducted and compared with Novolin-R, and Mixrelin was found to be bioequivalent. Next. The next drug I'll be talking about is Fetroja, or Cediferocol. Fetroja was approved November 14th of 2019 for the use of complicated urinary tract infections. It's a cephalosporin with a CD4 side chain. The side chain works by bonding iron, which gets actively transported into the gram-negative bacteria. This allows it to overcome some carbapenem-resistant mechanisms, and the cephalosporin portion bonds to penicillin bonding proteins, therefore inhibiting cell wall biosynthesis. As for IV dosing, as you can see, it's heavily dependent on renal adjustment. If the patient's renal clearance is over 120 milliliters per minute, the dosing is 2 grams every 6 hours, and the dosing goes all the way down to 750 milligrams every 12 hours for patients with poor renal function when it's less than 15 milliliters per minute. Also, infusion times are 3 hours regardless of the dose. Common adverse reactions include nausea, diarrhea, as well as a skin rash. Some serious adverse reactions include hypersensitivity reactions, Clostridium difficile-associated diarrhea, as well as increased mortality seen in critically ill patients when comparing it to Clostim for carbo-resistant gram-negative infections. Cediferocol comes in 1 gram vials. Each vial is $220 per vial at AWP. Once reconstituted, it will be a clear and colorless solution. However, when you store it, it needs to be refrigerated and protected from light. The interesting part about Fetroja when preparing it, it's reconstituted with 10 mL of normal saline, or D5, which is different from typical reconstitution of vials, which involves sterile water. Once reconstituted, it's added to 100 mL of normal saline, or D5W, whichever was used to reconstitute the vial originally. And at room temperature, when reconstituted, the vial is good for 1 hour, and when it's added to the solution, it's stable for 4 hours. This 4 hours is important because the infusion is 3 hours overall, so patients will have to be taught how to do a home mix, and if it's a lifetime dose, first lifetime dose, and if it's per your company's policy, a nurse will have to be there for the first dose. Next. To get approval, the study was Cediferocol versus imipenem-cilastatin for the treatment of complicated urinary tract infections caused by gram-negative uropathogens. It was a phase 2 randomized double-blind non-inferiority trial. There were 2 arms, one arm with 252 patients with Cediferocol 2 grams every 8 hours, and the other arm with 119 patients receiving imipenem-cilastatin 1 gram every 8 hours. The main outcome was clinical cure, with the Cediferol group having about 73% of the patients having clinical cure, and the imipenem-cilastatin group having about 55%. The adjusted treatment difference came out to be about 18.5%, which is statistically significant. The study has looked at adverse reactions for both groups as well. For the Cediferol group, had about 41% of patients experiencing adverse reaction, the most common being 12% of patients experiencing GI disorders. And about half the patients in the imipenem-cilastatin group experienced adverse reactions. Again, about 18% of patients experiencing GI disorders. Cediferocol was found to be non-inferior compared to imipenem-cilastatin for the treatment of complicated urinary tract infections in people with multi-drug resistant gram-negative infections.
Hi, my name is Susan Chen, and I'm a PGY1 resident with Fairview Pharmacy Services, and today I'll be talking about Vyondys 53. The Vyondys 53 was approved in December 12, 2019 under an accelerated approval program. It is an antisense oligonucleotide that's used for the treatment of Duchenne muscular dystrophy, or DMD, in patients with confirmed mutation of the DMD gene amenable to exon 53 skipping. This gene mutation leads to a minimal or no production of dystrophin, and dystrophin is an essential protein that keeps those muscle cells intact. DMD occurs in 1 in every 3,500 to 5,000 males born worldwide, and around 8% of these mutations have these mutations that are responsive to treatments with Vyondys 53. Vyondys 53 works by binding to exon 53 of dystrophin pre-mRNA and excludes the exon during the mRNA processing, and thereby allowing for production of shortened, partially functional dystrophin protein. It is dosed at 30 milligrams per kilogram via an IV infusion over 35 to 60 minutes and is done once weekly. It's really important for these patients that we monitor the GFR prior to initiation and during treatment, and that we administer the medication within 4 hours of dilution. There are 2 studies that were done on Vyondys 53 prior to it being approved for FDA approval. Part 1 was a 12-week randomized double-blind placebo-controlled trial that looked at the dose titration, specifically looking at safety, tolerability, and pharmacokinetics. Part 2 was a 168-week trial, open label, assessing the safety and the efficacy. The 12 patients that were in trial 1 were also enrolled then in part 2, and they also added then 13 additional patients. In terms of efficacy, they looked at the change from baseline and dystrophin protein level at week 48 compared to baseline, and they measured that using the Western blot. The mean dystrophin levels increased from 0.1% of normal at baseline to 1.02% of normal by week 48. And the mean change of dystrophin of 0.92% occurred of normal levels, which led to statistically significance. The median change from baseline of this dystrophin protein was 0.88%. For safety, the most common adverse reactions that occurred are headache, fever, falls, abdominal pain, nausea, vomiting, nasopharyngitis, and cough. Next slide. For warning and precautions for Vyondys 53, there were some hypersensitivity reactions. If this does occur, then we can consider slowing the infusion time. In addition, then renal toxicity was observed in studies that were done on animals. However, this information or renal toxicity was not apparent in the human studies. It is important to note that for renal function, creatinine may not be reliable in DMD patients. Therefore, for monitoring, we do recommend, or the package insert recommends, that we monitor GFR at baseline and during treatment, the urine analysis monthly, as well as serum cystatin C every 3 months. Vyondys 53 is supplied as a single-dose vial as 100 milligrams per 2 milliliters. It should be stored in the refrigerator in its original container and protected from light. If the product is diluted, it may be stored back in the refrigerator for up to 24 hours prior to use. The cost of Vyondys 53 is $1,920 per vial, and this is the average wholesale price.
Hello, this is Nita Vaughn. I'm the pharmacy resident at Option Care Health in Marlborough, Massachusetts. Today, I'm presenting a new drug information on Evenity. The generic name is Rebozo. Next page, please. Thank you. Evenity was approved by FDA on April 9, 2019. This is a monoclonal antibody, also known as sclerotin inhibitor. The indication for Evenity is to treat osteoporosis in postmenopausal women who are at high risk for fracture. Evenity is not indicated for use in females of reproductive potential. Evenity mechanism of action is to inhibit sclerotin. Sclerotin is a regulatory factor in bone metabolism that inhibit Wnt signaling pathway that regulate bone growth. Therefore, Evenity increases bone formation and, to a lesser extent, increases bone reabsorption. The box warning of Evenity is the potential risk of myocardial infarction, stroke, and cardiovascular death. Adverse reactions have been reported with Evenity, such as joint pain, headache, peripheral edema, muscle spasm, hypersensitivity reaction, hypocalcemia, and osteonecrosis of the jaw. Next page, please. Thank you. Here are two clinical trials on Evenity compared to other drugs. The first trial is known as ART trial. This was a phase 3 randomized control trial. There were 4,093 patients with osteoporosis who met at least one of the criteria that related to bone fracture. Half of the patients received sub-Q Evenity of 210 milligrams once monthly for 12 months. The other half of patients received oral alendronate of 70 milligrams once weekly for 12 months. The primary endpoint of the study was incidence of new vertebral fracture at 24 months. As a result, Evenity group found to have less incidence than the control group, and the p-value was less than 5%. The second trial is known as structured trial. This was also a phase 3 randomized control trial. There were 436 postmenopausal women with osteoporosis. Half of patients received sub-Q Evenity of 210 milligrams monthly for 12 months, and the other half patients received sub-Q teriparatide, also known as Forteo, of 20 micrograms daily for 12 months. The primary endpoint of this study was the percent change from baseline in total head bone mineral density at month 12. As a result, Evenity group found to have more percent change than the control group, and the p-value was less than 5%. Overall, the Evenity duration should be limited to 12 monthly dose because it is no longer benefit thereafter. If osteoporosis therapy is still needed, continue the therapy with anti-absorptive agents should be considered. Please note, we must correct the calcium level in patients with hypocalcemia prior initiate Evenity therapy. Next page, please. Thank you. Evenity is a subcutaneous injection that must give 2 consecutive injections for a total dose of 210 milligrams once monthly. There is no dosage adjustment for renal or hepatic impairment. We must monitor closely for hypocalcemia if patients have eGFR less than 30 or receiving dialysis. As part of preparation administration, allow Evenity to sit at room temperature for at least 30 minutes before injecting. The injection sites are abdomen, thigh, or outer area of upper arm. Evenity should be only administered by healthcare professionals. Pharmacy must dispense Evenity with a medication guide as well. For nursing considerations and monitoring, we should monitor for signs and symptoms of hypersensitivity, cardiovascular events, and patient weight. Lab assessment include serum calcium and bone mineral density. Evenity should be stored in the refrigerator between 2 Celsius to 8 Celsius in the original carton and protected from light. It may be stored at room temp in the original container up to 30 days. Do not expose greater temperatures than 25 Celsius. Do not freeze and do not shake. Evenity solution should be clear, colorless to like yellow solution. It is a single-use pre-filled syringe. Do not use if it's cloudy, discolored, or contain any particulate matter. The average wholesale price is $1,095 for 1 syringe, and each carton contains 2 syringes. For both of them are for 1 dose administration. As part of patient education, pharmacists should consult patients who are on Evenity to take supplements, calcium and vitamin D if dietary intake is not enough. If a dose is missed, administer SMS, it can be rescheduled. Subsequent dose should be scheduled every month from the date of last dose. Last but not least, pharmacists should counsel the patients about good mouth care and hygiene due to osteonecrosis of the jaw reported in patients receiving Efficacy. Next page is my references. Thank you.
Hi, my name is Eric Slayton. I'm a PGY1 pharmacy resident with Quorum CVS Specialty Infusion in Marietta, Georgia. I'll be covering Zimba Phi, an immunoglobulin product approved in July of 2019. Zimba Phi is an immunoglobulin product. It's a subcutaneous immunoglobulin product approved for the indication of primary humoral immunodeficiency. The mechanism of action is by providing immune support by Ig pathways. However, the detailed mechanisms of the support are not well known. To calculate the appropriate dose of Zimba Phi for patients converting from IVIG, first multiply that patient's current IVIG dose by 1.37. Then divide this result by the number of weeks between that patient's IVIG infusions. For patients converting from subcutaneous IG products, there's no need for any additional calculation. Simply maintain the same weekly dose. For dose adjustments on patients receiving Zimba Phi, IG troughs can be measured as early as 5 weeks after the initiation of therapy, after which point dose may be adjusted according to the detailed charts provided by the manufacturer in the package insert. The key phase 3 study for approval compared Zimba Phi to IVIG. It was found that Zimba Phi had similar levels of overall exposure, but less fluctuation in IG levels compared to IVIG. Also, the side effect profile was favorable, as the majority of side effects reported for Zimba Phi had merely to do with the subcutaneous route of administration. Zimba Phi is to be administered only by subcutaneous route. As previously described, doses may be administered weekly, or they may also be divided throughout the week. Up to 25 milliliters may be administered per site, with a maximum rate of 25 mLs per hour per site. And finally, up to 6 sites may be used per infusion. There are no specific warnings to this product. However, there are some warnings that are associated due to being warnings for the drug class at large. And some of those warnings include thrombosis, aseptic meningitis syndrome, hemolysis, and transfusion-related acute lung injury, otherwise known as TRALI. For patients receiving Zimba Phi, it's recommended that, of course, IG levels are monitored as well as renal function and blood counts. Zimba Phi is supplied as a 20% formulation, or 1 gram per 5 mLs. Vial sizes include 1, 2, 4, and 10 grams. It's recommended to be stored under refrigerated temperatures and may be exposed up to 25 degrees Celsius for no more than 6 weeks prior to expiration. The average wholesale price is just over $40 or $200 per gram.
My name is Shelby Dick, and I am a pharmacy resident at Option Care Health in the Lincoln, Nebraska location. And today I'll be going over 2 different antibiotics. So we'll start with Ricarbrio, which is a combination of imipenem, cilastatin, and relebactam. Imipenem is a carbapenem antibiotic, cilastatin is a renal dihydropeptidase inhibitor, and relebactam is the beta-lactamase inhibitor. And this was approved on July 17th, 2019. It's indicated for the treatment of complicated urinary tract infections and complicated intra-abdominal infections. For the mechanism of action of each component, imipenem binds to penicillin binding proteins in Enterobacteriaceae and Pseudomonas aeruginosa, and subsequently binds penicillin binding proteins, leading to the disruption of bacterial cell wall synthesis. Cilastatin is on board to limit the renal metabolism of imipenem, and relebactam is the beta-lactamase inhibitor that protects imipenem from degradation by serine beta-lactamases. Next slide, please. For dosing, it will be 1.25 grams, which is 500 milligrams of imipenem, 500 milligrams celastatin, and 250 milligrams of relebactam, given IV over 30 minutes every 6 hours in adults age 18 years and older who have a creatinine clearance of at least 90 milliliters per minute. There are dose adjustments for renal dysfunction, which I've included here. And I do want to make note in the bullet below that you should refer to the package insert for specific reconstitution instructions for the renal adjustment doses. Next slide, please. For preparation, I did want to go through this because it is unique. So you'll withdraw 20 milliliters and 10 milliliter aliquots from an appropriate 100 milliliter infusion bag, and the appropriate products are shown there. You'll reconstitute the vial with one 10 milliliter aliquot and shake that well and transfer it back to the infusion bag. You'll then take the remaining 10 milliliter aliquot and transfer it to the empty vial and shake it well to ensure the complete transfer of all vial contents. You'll then transfer that remaining 10 milliliters back to the infusion bag for a total volume of 100 milliliters. And as I mentioned earlier, you should refer to the package insert for reconstitution instructions if you are using a renally adjusted dose. And the reconstituted solution should range from colorless to yellow. These vials should be stored at room temperature, and the reconstituted and diluted solution is stable for 2 hours at room temperature and 24 hours refrigerated, and it should not be frozen. Ricarbrio is fairly well tolerated. There are some adverse reactions that had been reported, and those include headache, diarrhea, vomiting, increased liver function tests, and since it's an infusion, it has been associated with phlebitis, infusion site pain, and erythema. For some precautions, they do give central nervous system reactions as a precaution, with seizures being reported with the parent drug, so they have carried this risk over to this new combination antibiotic. They also give the risk of C. diff-associated diarrhea and hypersensitivity reactions in patients with beta-lactam allergies. For drug interactions, they recommend avoiding the use with ganciclovir, valproic acid, and divalproic sodium due to the risk of seizure potential, and the cost is $321 per vial. Initial determination of the efficacy and safety of Ricarbrio was supported by the previous findings of the safety and efficacy of the parent drug, imipenem celastatin, for the treatment of intra-abdominal infections and UTIs. The contribution of relebactam to the parent drug was assessed through in vitro and in animal studies with infection. There is one noteworthy trial out there called Restore-IMI, and this was a randomized controlled double-blind trial to evaluate the efficacy and safety of Ricarbrio. And this trial looked at hospitalized patients with hospital-acquired pneumonia, complicated intra-abdominal infections, and complicated urinary tract infections. And these patients were randomized to 5 to 21 days of imipenem relebactam or imipenem colistin therapy. And they found that imipenem relebactam was found to be effective for the treatment of carbapenem non-susceptible gram-negative infections and was also associated with less nephrotoxicity compared to colistin-based therapy. And next we'll go through Zenleta, also known as Lefm Yulin. And this is a pleuromutilin antibiotic that was approved August 19th, 2019, and it's indicated for the treatment of community-acquired bacterial pneumonia. For its mechanism, it inhibits bacterial protein synthesis by blocking sites on the ribosomal RNA. The binding pocket of the bacterial ribosome then closes around the mutilin core for an induced fit that prevents correct positioning of transfer RNA, ultimately blocking bacterial replication. For spectrum activity, it works well against strep pneumoniae, Staph aureus, specifically methicillin susceptible, Haemophilus influenza, Legionella, Mycoplasma pneumoniae, and Chlamydophila pneumoniae. I do want to make note that it is not approved for the treatment of bacterial pneumonia caused by methicillin-resistant Staph aureus. For For dosing, it does come in both IV and oral formulations. The IV dosing is 150 milligrams every 12 hours. There is a dose adjustment for severe hepatic impairment down to 150 milligrams every 24 hours. The oral dosing is 600 milligrams every 12 hours, and it is not recommended for use in patients who have moderate to severe hepatic impairment. The total duration of treatment should be a minimum of 5 days, and this does vary based on disease severity and response to therapy. Patients should remain afebrile and stable for at least 48 hours prior to discontinuing therapy. For preparation, you will dilute the entire 15 milliliter Lefm Yulin vial into the provided diluent bag, and this provided diluent bag is 250 milliliters of 10 millimole citrate buffered normal saline, and you'll mix that thoroughly. The solution should be clear and should be discarded if there's any particulate matter or discoloration visible. Adverse reactions does depend on the dosage form, but both formulations were shown to have hepatic enzyme elevation. The injectable formulation was found to have site reactions, nausea, hypokalemia, headache, and insomnia for some of the more common adverse reactions. And the tablet formulation had primarily GI symptoms like diarrhea, nausea, and vomiting. They do warn that this medication can cause QT prolongation, and patients should be monitored if they are on other QT prolonging medications. This antibiotic can also cause a superinfection by C. diff. It can cause hepatic impairment if the patient is on this antibiotic long term, and it can also cause embryo-fetal harm. Zenletta is a CYP3A4 substrate, so you should use caution with strong CYP3A4 inducers or inhibitors. For administration, the IV formulation should be infused over 60 minutes, and the oral formulation should be given on an empty stomach, at least 1 hour before a meal or 2 hours after a meal. Should also be swallowed whole with 6 to 8 ounces of water. For storage, the vials should be stored in the refrigerator and they should not be frozen. The provided diluent bag should be stored at room temperature. The diluted product is stable for 24 hours at room temperature and 48 hours refrigerated, and the tablets should be stored at controlled room temperature. And for cost, for the injectable formulation is labeled per milliliter, so it's $8.20 per milliliter or $246 per day. And the tablets are $165 each. And finally, I did want to go through some noteworthy clinical trial data. There were 2 studies, LEAP-1 and LEAP-2, and these were both randomized, double-blind, non-inferiority trials looking at Zenletta for the treatment of community-acquired bacterial pneumonia. LEAP-1 compared 5 to 10 days of IV transitioning to oral Zenletta compared to 7 to 10 days of IV transitioning to oral moxifloxacin with or without the use of linezolid. And LEAP-2 looked primarily at the oral formulation of Zenletta compared to the oral formulation of moxifloxacin. And what they found was that both trials showed that Zenletta was non-inferior compared to moxifloxacin in achieving early clinical response for the treatment of community-acquired bacterial pneumonia.
Hi, my name is Christina Nguyen. I'm one of the pharmacy residents at Quorum CVS Specialty Infusion Services located at Houston, Texas. Today I'll be presenting on Boncity and Biologics. So Boncity, which is also known as teriparatide, is a parathyroid hormone analog. It was approved last year in October of 2019. There are currently 3 FDA-approved indications for this medication. It is indicated in the treatment of postmenopausal women with osteoporosis and at high risk for fracture. It can also be used to increase bone mass in men with primary or hypogonadal osteoporosis and are at high risk for fracture. The last indication is for the treatment of men and women with osteoporosis associated with sustained systemic glucocorticoid therapy and at high risk for fracture. The dose is set at 20 milligrams sub-Q daily for up to 2 years. Afterwards, it is currently not recommended to use a medication for more than 2 years during a patient's lifetime due to the lack of safety and efficacy data beyond that time period. Since there are 3 different indications for Bonsi, there are 3 different trials. Each were randomized double-blind controlled trials. The first 2 compared Bonsi with placebo, and the last one compared it with an active comparator. Overall, each trial saw an increase in bone mineral density in all sites from baseline, and the first trial also saw a reduced risk of 1 or more new vertebral or non-vertebral fractures. Next slide. Bonsi has a black box warning for potential risk of osteosarcoma since animal studies showed that teriparatide caused an increased incidence of osteosarcoma. The most common adverse reactions seen in clinical trials were arthralgia, pain, and nausea. In clinical trials, transient orthostatic hypotension was observed in a small number of patients. And due to this, it is recommended that Bonsi is administered under circumstances where a patient can sit or lay down. Also, Bonsi was not studied in patients with active urolithiasis, so caution should be used in order to prevent an exacerbation. And other monitoring parameters will include serum and urinary calcium and bone mineral density. Bonsi is supplied as a single patient use pen, and it should be refrigerated at all times. The dose can be given immediately after removal from the fridge. It is administered sub-Q into the thigh or abdominal wall. And like I mentioned before, the initial injection should be given when the patient can sit or lay down. And patients and caregivers that are administering this product should receive appropriate training and instruction. Next slide. Okay, so the next drug is Vyleesi, which is also known as bremelanotide. It is a melanocortin receptor agonist for the treatment of premenopausal women with acquired generalized hypoactive sexual desire disorder, also known as HSDD. It was approved by the FDA last year in June 2019. This medication is dosed at 1.75 milligrams sub-Q as needed at least 45 minutes before sexual activity. Next slide. The phase 3 trial for Vyleesi was the Reconnect trial, or otherwise titled Efficacy of bremelanotide for Hypoactive Sexual Desire Disorder. It was a randomized double-blind placebo-controlled trial that took place over 24 weeks. Afterwards, there was an optional 52-week open-label extension study period. In the trial, they did find a statistically significant increase in FSFI desire domain score, which is a female sexual function index, and statistically significant decrease in FSDS-DAO Q13 score, which is the female sexual distress scale, desire, arousal, orgasm question 13. A higher FSFI score means an improvement in sexual desire, and a lower FSDS-DAO score means improvement in level distress associated with low sexual desire. The most common adverse reaction seen was nausea, flushing, and headache. Like I mentioned before, the most common adverse reaction seen in the clinical trials was nausea and flushing, and in addition, injection site reactions and headache. Vomiting was also seen, but not as common. They also saw a transient increase in blood pressure and a decrease in heart rate during clinical trials, so caution should be used in patients with cardiovascular risks. It is contraindicated in patients with uncontrolled hypertension or known cardiovascular disease. Some important counseling points for patients is to make sure they use an effective contraception due to the unknown risks that Vyleesi has. And also due to the nature of how the medication works, it is important to let the patient know that they may experience patches of darkened skin, including the face, gums, and chest area. Patients with darker skin complexion are more likely to develop this, and it's not confirmed from clinical trials whether this resolved after discontinuing treatment. So each Vyleesi dose is supplied at 1.75 milligram in 0.3 ml solution as a single dose in a disposable pre-filled auto-injector. Each carton will contain 4 auto-injectors. It is stored in the refrigerator and should be protected from light. Patients should administer it sub-Q into the abdomen or thigh area, and it's not recommended to administer more than 1 dose in 24 hours and no more than 8 doses per month. The AWP is around $270 for each auto-injector, and there is a $0 copay card on the first prescription. However, afterwards is a max $99 copay for 1 box of 4 auto-injectors, and this can be used for 2 fills every 30 days.
Hi, my name is Dustin. I'm the pharmacy resident with Option Care from Philadelphia. I'm going to be talking about 2 drugs, the first one being Rebozo. So Rebozo was approved in 2019 in November for the treatment of beta thalassemia anemias and patients that require regular blood transfusions due to the disease state. So the starting dose here is 1 mg per kg, and it's given every 3 weeks, and it's a subcutaneous injection. If there's no reduction in red blood cell transfusions after 2 doses, you can actually increase the dose per recommendation of the package insert. The main monitoring parameter is to look at the hemoglobin, which is supposedly supposed to be 11 grams per deciliter or lower before you start therapy. Some serious adverse reactions include thrombosis and thromboembolisms, and it's known to be cause fetal harm. So the cost of the medication, it comes in 2 vials, a 25 milligram and a 75 milligram. The first being a little over $4,000 and the latter being a little over $12,000. The appearance of the product is a yellow solution, clear with free of particle matter. Storage conditions include refrigeration and to protect from light and to not freeze the medication. On the package insert, it gives the preparation instructions. So we do want to mix with sterile water. It's the only diluent listed on there, so you can't use normal saline. So with sterile water, allow the product to sit for 1 minute and then gently swirl for 30 seconds and let the vial sit upright for another 30 seconds. And then basically repeat this process until it's in solution. Stability information included on the package insert is 8 hours at room temperature and 24 hours refrigerated. So from a home infusion perspective, this would most likely be a therapy we give in a home infusion suite, or we send to the patient's house to actually have them administer it in a vial themselves due to the short stability. For nursing parameters, monitoring for signs and symptoms of the thromboembolic events is key, along with monitoring blood pressures, because the product is known to cause hypertension. So there is clinical data for the Rebozo products, and it's called the BELIEVE trial. And it was a 2-arm study looking at patients that received the medication versus patients that did not. And I just want to direct your attention to the response column, the second column there, or the second row there, my apologies. And the treatment percentage is a little over 20% compared to 4% in the patients that didn't receive the therapy. And basically what that percentage is saying is that those patients had a response, which was defined as a reduction of at least 2 units for 3 consecutive doses of the red blood cell transfusions. You can go to the next slide. So my second drug is in HER2, which is a trastuzumab derivative for HER2 positive breast cancer in the metastatic setting. Medication was approved in December of 2019. Dosings include, it's an IV route formulation only with dosing 4.5 milligrams per kg every 3 weeks. And noted on the package insert, the first dose should be over 90 minutes. Serious adverse reactions include neutropenia, left ventricular dysfunction, and 2 black box warnings for interstitial lung disease and embryo fetal harm. So the cost of this medication, it only comes in 1 vial, which is a 100 milligram vial, and it's roughly $2,700. The appearance here is a is a clear colorless solution to like a light yellow, and the storage conditions are under refrigeration and protect from light. And due to it being of like a monoclonal antibody nature, we do not want to shake the product as well. Preparation is to use sterile water for injection, ultimately giving concentration of 20 mg per milliliter. Nursing considerations for this product: for the reconstitution solution, again, really short stability life, so 24 hours under refrigeration. So most likely another home mix or a medication we give right in the home infusion suite. And we must use a 0.2 micron inline filter for the product. So the clinical data on this product is labeled as the Destiny trial. Overall, looked at patients who had some form of malignancy, and they categorized the malignancies based on the presence of the HER2 receptor. So more than half of those patients actually had the HER2 receptor malignancy. And in the treatment, 56 patients received partial response, and out of that 56, 60% actually had a complete response. So overall, good efficacy for the medication. Most common side effects were similar to what chemo medications are: nausea, vomiting, hair loss, constipation, neutropenia, and respiratory tract infections.
Hi, my name is Jordan Menkoff, and I'm a PGY1 Health System Pharmacy Administration and Leadership Resident with Fairview Pharmacy Services. And today I'll be talking about Zulresso, or brexanolone. Zulresso was approved in March 2019 and is a gamma aminobutyric acid A receptor positive modulator and is indicated for postpartum depression. Its mechanism of action is not fully understood, but it's thought to be related to its positive allosteric modulation of GABA A receptors. Next slide. Zulresso has a box warning for excessive sedation and sudden loss of consciousness. For monitoring, it requires monitoring for excessive sedation every 2 hours during planned non-sleep periods and requires continuous pulse oximetry monitoring. Certain populations to look out for with Zulresso: it is safe for breastfeeding with a relative infant dose of 1 to 2%. In general, breastfeeding is considered acceptable when the relative infant dose of a medication is under 10%. Zulresso should be avoided in patients with end-stage renal disease with an eGFR of 15 or less. Zulresso also has a REMS program with specific facility, pharmacy, wholesaler, and patient requirements. This slide outlines the dosing strategy for Zulresso, and it is a continuous 60-hour infusions with a titration schedule starting at 30 mics per kg per hour and increasing and decreasing throughout the 60 hours. Next slide. So looking at the first study that got Zulresso approved, looked at 138 women with a Hamilton D score for postpartum depression greater than or equal to 26, randomized 1:1:1 to receive brexanolone 90 mics per kg per hour, 60 mics per kg per hour, or placebo for 60 hours. And this Hamilton D score was for severe postpartum depression. And so the efficacy of Zulresso in this trial, in the change at 60 hours, in the group that received 90 mics per kg per hour, the score decreased -17.7. In the 60 mics per kg per hour, decreased -19.5, and placebo decreased by 14. At 60 days, this was maintained in the 90 group at -17.6, -19.5 in the 60 group, and -13.8 in the placebo group. And for safety, the most common side effects that were found were headache, dizziness, somnolence. And one patient in the 60 group had suicidal ideation and intentional overdose during follow-up. In the moderate postpartum depression study, 108 women with a Hamilton D score of 20 to 25 were randomized 1:1 to receive 90 mics per kg per hour or placebo for 60 hours. At 60 hours, the group that received drug had a score decrease of -14.6 and placebo -12.1. And at 60 days, the group that received drug, their score decreased -14.7 and placebo -15.2. Safety, most common side effects found were headache, dizziness, and somnolence, and one patient in the group with drug had altered state of consciousness and syncope. Zulresso is supplied with a 100 milligram per 20 ml single-dose vial, which must be diluted before administration, diluted in an empty bag with 40 ml of sterile water for injection, and further diluted with 40 ml of normal saline for a total volume of 100 ml to achieve a target concentration of 1 milligram per ml. Storage, the refrigerated product must be refrigerated and protected from light. And once diluted, the product can be refrigerated for up to 96 hours, and the diluted product can be used for only 12 hours at room temperature. This means for the infusion, you need a minimum of 5 bags of Zulresso. The cost of Zulresso average wholesale price is $8,940 per vial. Some nursing consideration, you must use a PVC non-DEHP non-latex infusion set and must use a programmable pump with a dedicated line.
Hi, my name is Sophia Shrestha, and I'm a PGY1 pharmacy resident with Fairview Pharmacy Services. And the first drug I'll be reviewing today is Adakveo, or crizanlizumab. Adakveo is a selectin-targeted monoclonal antibody that was approved last year in November, and it's indicated for use in sickle cell disease, specifically to reduce the frequency of vaso-occlusive crises in patients 16 years of age and older. It works by binding to P-selectin that's expressed on activated endothelium and platelet cells, which blocks the interaction between endothelial cells, platelets, red blood cells, and leukocytes to prevent vaso-occlusion. It's dosed at 5 milligrams per kilograms, given intravenously over 30 minutes. The initial dose is given at week 0 with a loading dose followed in week 2, and subsequent maintenance doses are given at week 6 and every 4 weeks thereafter. The 5 milligram per kilogram dose is based off of the patient's actual body weight, and it can be given with or without hydroxyurea, which is the cornerstone of treatment for sickle cell disease. For the stability of the prepared product, if it's in room temperature, it has a stability of 4.5 hours, whereas in refrigeration, it's stable for 24 hours, and that time includes time from start of preparation to completion of the infusion. Some administration consideration, it has to be administered using a 0.2 micron filter and should not be co-administered or mixed with other drugs in the same IV line. After administration, the line must be flushed with saline or D5W. For missed doses, if the missed dose is administered within 2 weeks after the originally scheduled dose, you may continue the original schedule, whereas if administered more than 2 weeks after the originally missed dose, then a new every 4-week scheduling must be started. Adakveo was approved based on results from the SUSTAIN clinical trial, which was a phase 2 randomized, placebo-controlled, double-blind study with patients followed up for up to 52 weeks. The primary endpoint was the median annual rate of pain crisis, where individuals on Adakveo had a significantly greater reduction in the number of pain crises, with a 45.3% reduction in annual rate of pain crisis seen with those on Adakveo. Secondary endpoint included time to first pain crisis, which was also significantly longer with Adakveo compared to placebo. They did not, however, find any difference in the rate of days hospitalized, rate of uncomplicated pain crisis, and the rate of acute chest syndrome. Some safety considerations for Adakveo. There is a risk for infusion-related reactions. 3% of those in the clinical trials did experience a reaction. However, the recommendation is to just monitor for signs and symptoms of reaction after infusion. It may also interfere with laboratory tests, specifically with automated platelet counts where you may observe platelet clumping. And the most common adverse reactions seen with Adakveo in clinical trials included headache, back pain, gastrointestinal side effects, risk of infections, as well as pruritus and chest pain. Patients who are pregnant, it has been shown to cause fetal harm. However, we don't know any safety or efficacy data in pediatric patients less than 16 years of age. And lastly, for Adakveo, it is available as a 100 milligrams per 10 ml solution in a single dose vial, which must be stored under refrigeration and protected from light. The cost is about $2,800 per vial. And given that the drug is dosed based off of weight, if we're assuming an 80 kilo patient, the annual cost is approximately about $113,000 per year. And here are my references. The next drug I will be talking about is Aston M, which is an immune globulin IV product. It is a plasma-derived polyclonal immune globulin IV liquid that was approved last year in April, and it's indicated for use in primary humoral immunodeficiency in both adults as well as adolescents. And it works as a replacement therapy for immunodeficiencies. So by providing a broad spectrum of neutralizing IgG antibodies against both bacterial and viral pathogens, the goal is to avoid recurrent opportunistic infections. The dosing of Aston M, it's dosed at 300 to 800 milligrams per kilogram every 3 to 4 weeks with an initial infusion rate starting with 0.5 milligrams per kilogram per minute for the first 15 minutes and can be titrated up to a maximum of 8 milligrams per kilogram per minute if tolerated. There may be dosing adjustments needed for patients who fail to maintain a trough of at least 500 milligrams per deciliter for their total IgG. Individuals with renal insufficiency, it's important to ensure patients are not volume depleted and that we are administering at the minimum infusion rate that's possible and to discontinue the drug if renal function deteriorates. Some specific administration consideration, the drug must be used only for intravenous use. It has to be brought to room temperature before using and should not be shaken, diluted, or mixed with any other IG products. And it is important to monitor vital signs throughout the infusion and, if needed, slow or stop the infusion if a reaction were to occur. Aston M was studied in a clinical trial that was prospective, open label, single arm to determine both the efficacy, safety, as well as pharmacokinetics of the drug in both adult and adolescent subjects. So 59 individuals were followed for up to 12 months with the primary endpoint of confirmed serious acute bacterial infections. And these included infections such as pneumonia, bacteremia, osteomyelitis, visceral abscess, and bacterial meningitis, of which there were 0 confirmed cases. Some other endpoints they evaluated included looking at rate of other infections, antibiotic use, days off of school or work, unscheduled medical visits, and hospitalizations, all due to infections. In this clinical trial, 98% of the individuals did have adverse reactions, which I will now discuss. So like other IVIG products, there is a black box warning for thrombosis and renal dysfunction as well as acute renal failure. And it is contraindicated for use in those with hypersensitivity to human immune globulin, as well as IgA deficiency patients with IgA antibodies. The adverse reactions that occurred in the clinical trials included primarily headaches, sinusitis, diarrhea, gastrointestinal and respiratory tract infections. And similar to other IVIG products, there are very similar warnings and precautions as well. For monitoring, it is important to monitor the renal function, BUN, and creatinine before and during therapy, and also consider a baseline blood viscosity test. There may be interactions with live vaccines with risk of passive transfer of antibodies that may interfere with immune response to live virus vaccines. And in geriatric patients who are at risk for renal insufficiency, it is important that we do not exceed the recommended dose and infusion rate. And lastly, we currently know that for pregnancy as well as lactation, there is no known harm of using Aston M in that population. And lastly, Aston M is available as a 5 gram per 50 ml single-use vial, which must be stored under refrigeration and should not be frozen or heated. And the cost per vial is about $5,400.
Hi, my name is Rachel Delavar, and I'm a PGY resident with Quorum CVS Specialty Infusion Services in Milwaukee, Wisconsin. And next, I'll be going over Espract, or Teractagogue alpha-pegol, also known as N8GP. So Espract is a coagulation factor 8 concentrate that has been conjugated to a polyethylene glycol molecule for the purpose of increasing the half-life and decreasing the rate of clearance, therefore allowing the molecule to remain in the body for longer and have an extended duration of effect. It was approved in February of last year and is indicated for the treatment of adults and children both with hemophilia A for on-demand treatment and control of bleeding episodes, perioperative management of bleeding, as well as routine prophylaxis against bleeding. So dosing depends on the indication as well as the age of the patient and is outlined here on this slide. The dose for patients 12 or older ranges from 40 to 50 units per kilogram, depending on the indication and severity of bleed. And the standard dose for patients under 12 years old is 65 units per kilogram. Of note, dosing can also be done to achieve a specific target factor 8 activity level, and the equation for that is listed at the bottom of this slide. So Esperact is supplied as single-dose vials and comes in 5 different strengths ranging from 500 to 3,000 units per vial. And the average wholesale price is reported to be $2.68 per each, meaning per unit, and it should be protected from light and stored under refrigeration. And for the powder, it can be used for up to 30 months if refrigerated or 12 months at room temperature. But once it's reconstituted, it must be used within 24 hours if refrigerated or 4 hours if left at room temperature. It's for IV administration only, and the package that it's supplied in includes a pre-filled diluent syringe, which should be used exclusively for the reconstitution of the vial. And then it should be given slowly as an IV push over 2 minutes. So here I will be talking about some of the clinical trials that were done to test the safety and efficacy of Esperact. In the first trial, there were 186 adult and adolescent subjects. 175 of those received a prophylactic dose of 50 units per kilogram every 4 days, and 12 of the adults chose to be treated on demand. Of note, one of the subjects started in the on-demand group, but then decided midway through to switch to the prophylactic group, and so he was actually counted in both groups for the analyses. And what they found was that in the prophylactic group, 105 of the 175 subjects needed treatment for bleeding episodes, while in the on-demand group, all 12 of the subjects were treated for bleeding episodes. In the on-demand group, all of the subjects had spontaneous bleeds, 10 of the 12 had traumatic bleeds, and all 12 of them had joint bleeds. In terms of efficacy, there were 15 cases of severe bleeds, of which 80% needed more than 1 dose to treat, with an overall median dose of 111 units per kilogram. There were also 1,407 cases of mild to moderate bleeds, for which 76.4% in the prophylactic group and 88.4% in the on-demand group were able to be treated with just a single dose of Esperact. Then in the pediatric trial, 68 subjects were enrolled, all of which received a prophylactic dose of 65 units per kilogram twice weekly. And they found that 39 of the subjects were treated for bleeds during the study, with a total of 70 bleeding episodes, all of which were classified as either moderate to mild bleeds. Of these, 37% of the episodes required greater than 1 dose of Esperact to treat, with a median total dose of 70 units per kilogram. So overall, these studies showed that Esperact was safe and effective for the treatment of bleeding episodes, and when given prophylactically, it could also reduce the frequency and severity of bleeds. All right, then lastly, just for completeness sake, we've included a list of some additional biologics and biosimilars which have not already been discussed. And so this table is just for your reference, and it will not be discussed in detail.
NHIA would like to thank the home infusion and specialty pharmacy industry residents for their hard work on this project. This program is approved for 1.5 CEU contact hours. Thank you.